We are going to get started. Thank you everyone for joining us for putting public health expertise into action. This is an HCET webinar. If you're here to talk about putting public health expertise into action, you are in the right place. We are excited to have you join us. Today we are really excited to have presenters from NCSD. We have Christopher Zifulich, who's going to be leading us through today's talk. But first, I'm just going to go over a couple of housekeeping things from HCT. Chris, if you wouldn't mind switching us to the next slide. So today's webinar is being recorded. We will put it online after it's over on our YouTube channel. There is the ability to enable closed captions if you would like to view those on your screen. You can see down at the bottom, there's a bar where you see a little CC. Just click on that and you can enable your closed captions. Thank you, Chris. Next slide, please. And then for questions, we will use the Q&A function. So you'll see down at the bottom as well, Q&A. You can put in a question anytime during the webinar. You don't have to wait till the end to do it, but we will address questions at the end. And then I know Chris will also be engaging people during the webinar to use the chat as well. So you will be prompted to use the chat when we should do so. Other than that, questions, please submit them through Q&A and we will address those at the end. Awesome. Next slide, please. Please follow us on our social media channels. We talk about things related to sexual and reproductive health. We're on Facebook, Instagram, at hcet.org. And I think at the beginning, I actually forgot even to tell you what HCET was. I apologize for that. HCET is a nonprofit. We are people who are passionate about sexual and reproductive health education and care. We believe that, accurate, comprehensive, medically sound sexual and reproductive health and education surrounding it is a human right. So that's why we're here. That's why we have wonderful speakers to talk to you all as experts in public health to help you do the work that you do so well, because we know that it's so important. So thank you for being here to join us today. Next slide, please. Oh, perfect. Thank you, Chris. So after this webinar, we will post a QR code that has an eval, and we will also send a link in an email follow-up. We really, really appreciate you taking the time to fill out an evaluation. This just helps us know what we're doing well, know what we need to work on, and helps us plan for the future. We do ask for your thoughts on what other topics you'd like to hear about. So we appreciate and ask you in advance if you'd please fill out the evaluation after. It's really short. It shouldn't take you more than 3 or 4 minutes. And so now I'm actually going to turn things over to Diana Rono, NCSD's Director of State Policy, just to give us a little background on NCSD. All over to you, Diana.
Thank you, Adele. Thank you so much. Good afternoon, everyone, and welcome. My name is Diana Rono. I'm the Director of State Policy here at the National Coalition of STD Directors, and I am joined by my colleague and your presenter, NCSD's famous Senior Manager of State Policy and Training, Christopher Zifulich. So we thank you for joining us today as we provide some insight and expertise around navigating policy in the public health space. Next slide. Okay, so who is the National Coalition of STD Directors? Well, we represent and serve the nation's STI professionals who address the STI epidemics occurring across the United States. This is our big picture. Our mission is to advance equitable, effective STI prevention programs and services in all communities across the country. And we do this as the voice of our members and our membership. So who are those members? Next slide. So we represent over 6,000 STI professionals currently. Among them, we have our historic membership, right? This comprises of the 65 STI directors who lead prevention programs in every state health department, along with 8 territories and 7 large cities. So, and in addition to them, we serve more than 1,400 clinic members and 1,800 disease intervention specialists. Next slide. Okay, lots of text here, but at NCSD, we have teams dedicated to program technical assistance and evaluation, leadership training, DIS networking, 340B education, federal policy, such as through our popular Priority One briefings, which some of you may know about, but we will drop a link into the chat if you'd like to learn more about our Priority One briefings and sign up. And then we also have a small but mighty team dedicated to state policy. That is comprised of Christopher, and myself. And the examples on this slide are really just a snippet of what we do in state policy. Essentially, we provide targeted policy-focused training and technical assistance. We increase awareness of policy environments and how these rapidly changing environments impact state and local STI and HIV programs. We educate STI and HIV program staff on how to safely communicate with stakeholders, such as in today's presentation. We create and promote materials that document HIV and STI program successes, and we promote awareness of your STI and HIV programs among national audiences, all of which, in a way, brings us here today for this webinar. So, next slide. Okay, great. With that, Chris, I will hand it over to you to take us away. Thank you.
Yes, thank you, Diana. Thank you to Adele and everybody at HCT for having us today for this talk. This is one of our favorite things to talk about, that when you are a public health professional, there are many ways that you can engage the policy world and put your expertise into action. And so I'm very excited for today's talk, and I'm looking forward to connecting with you all. I'm going to go through a lot of information because this is our effort to kind of hit the surface level of lots of different options out there. And so please, please, please do not be afraid of that Q&A box. If we don't know the answer to something, we will for sure let you know. But otherwise, because we're tackling the surface level of a lot of this work, I imagine it may prompt several questions from you all. So please do not be afraid to use that. There's no such thing as a dumb question. We love all questions, and I just want to really encourage folks to not be afraid to put something in that Q&A box. In fact, going to this title, putting public health expertise into action, there are many ways to do it, but we are looking at the policy change world through today's conversation because it's a very effective way to take your expertise and see real change happen in your jurisdiction. And of course, that is the background of our state policy work here at NCSD. So we feel like it speaks to a lot of what we can talk about with you. And as I kind of just alluded to, sometimes in the public health world, especially if you work for a governmental agency like a state or local government, you can kind of immediately see people sometimes shut down and be like, oh gosh, I can't lobby, so I can't do anything with policy. I don't want to touch that. And our big goal is to say, oh my gosh, there's so many different ways you can engage with that world. And yeah, it is good to know what is allowed and not allowed, especially when it comes to lobbying. And we're going to actually talk about that today. But there's so many ways where, as this slide says, you can navigate policy, take the data and the best practices that you have through your public health expertise and turn it into storytelling, turn it into policies, and make real policy change. So that's my little preamble, but we're going to actually get into it now. Okay. And like all good things, we're going to start with a warm-up. So please use the chat for this warm-up. I would love to see where folks are at. On a scale of 1 to 10, or in some ways a scale of 1 to Demi Lovato, I'll explain in a moment, I would like to know, how would you rank your confidence with enacting policy change? So not just understanding policy as a whole, right? But overall, how would you rate your confidence to be involved in the process? So if you're like first of all, I know this is not 12 centimeters, which might be very unsatisfying to people, so we're going to ignore that for a moment. But if you're on the 0 to 1 side, it's like you're not very confident at all. If you're feeling generally confident, you're somewhere here in the middle. And then if you're like the Demi Lovato song, What's Wrong with Being Confident? which is a great song if you haven't heard it, then maybe you're over here in the 9 to 10 range. No wrong answers here. Just want to see where folks are at. So let me look at the chat as it blows up. Seeing some twos, some threes. Okay. A little bit of fours, occasional six. There's a lot of you, so. Oh, and I really appreciate Sarah saying it depends on the topic. That's a very fair qualification to add there, because sometimes, if it's something you've been involved in extensively, you might be on the Demi Lovato side of things, right? And then other times you might be like, I'm over here at 0 centimeters. I guess I did say 1 to 10, so the metrics of this are a little wonky, but okay. So I am seeing a lot of people on the left-hand side of the generally confident, which I think is really good because we're doing a lot of sort of foundational 101 stuff today. So hopefully for the folks that are between 0 to 5, you really get some of that foundational understanding of policy. And then for those of you who might be a little farther ahead, especially on specific topics, that's okay too, because hopefully some of this will be a refresher for you or allow you to ask some more complex or nuanced questions. So thank you all for participating in the chat on that. I have like 3 screens up right now between my notes, links I'm going to share later, and the slides and the Zoom. So if you see me looking all over, that's why. Okay. So we want to break down the basics of policy, and we're going to do it through the lens that we employ here at NCSD, especially through our state and federal policy work and our policy academy. There's like 2 camps that you can think of when it comes to policy change. One that we refer to as big P policy or legislative policy, and another that we refer to as little p or non-legislative policy. And so we're going to talk about both today, and specifically, we're going to talk about both from the perspective of working as a public health professional, especially in governmental entities, so you can kind of understand what options exist for you if you do want to take that expertise and turn it into policy action. Does it make sense to look at some big P policy or little p policy, and what does that include? So here on the big P policy side, I have a couple of different options we want to talk about. Obviously, when we're talking legislative policy, we are, of course, talking about legislation in and of itself. One of the most important things public health professionals can do, and we will unpack this a little bit more later, is educate lawmakers. Educating is different than lobbying. That's the thing we're going to talk about a little bit more in depth. But this is definitely one of the points we love to drive home, is that there are many different ways that you can educate lawmakers on factual information, especially on pending or prospective legislation, so that they can make the best decision when it comes to public health. Surprise, surprise, most of our policymakers are not public health professionals, and you might be shocked actually at the and I don't say this in a mean way, but just the lack of knowledge and some of the things that are our expertise. There's a lot of policymakers out there that are not aware at all, for example, that there's a congenital syphilis crisis going on. They might not have even heard the term congenital syphilis before. So educating lawmakers is a huge component of legislative policy. There's also ways that you can formally engage this within the system you work in. So for example, if you work in a health department, you probably have a legislative liaison, somebody who is specifically assigned to work with the legislature on behalf of the health department. And so depending on who that person is or the parameters of your role, that's somebody that you can engage potentially. Or it might just be somebody you can even just introduce yourself to and say, hey, I'm so-and-so, I'm a public health nurse. These are the things that I'm seeing, and I just want this to be on your radar. Because sometimes legislative liaisons, when they're dealing with departmental priorities for legislative sessions, if they know like, oh, wait a minute, yeah, I met a public health nurse who knows all about this, they might know to go to you for your expertise, especially if there's a bill pending, let's say, that, impacts something in the public health realm. Now, you may not have a legislative liaison depending on your role. There may be people with similar roles. There may be, for example, legal teams that work for your organization who play more of a specific role in the legislature. So really just understanding sort of the different teams and specific individuals who regularly touch the legislative world is a great tactic, because then you know who you might want to build a relationship with when it comes to potential legislation. There's also the regulatory and rulemaking process. This is, something where often through legislators there is, an effort to grant an agency, for example, some kind of rulemaking authority. I'm going to actually show an example of this in a little bit. Regulations are really interesting because this is where it can kind of teeter a little bit between big P and little p, right? Maybe the legislature authorizes something and then the health department might enact or implement something. And like I said, I'll show an example in a moment. But the regulatory and rulemaking process, is also within this big P policy camp. And then finally, with big P and legislative policy, we talk a lot about replication strategies. In the legislative world, cheating off your neighbor's paper is actually a good thing in many cases, right? We learned not to do that in school. But when we're talking good public health policy, it is actually very beneficial to look at other jurisdictions, see what's working very well for them, especially if the jurisdiction's makeup is similar to your own. So, for example, we're talking, let's say, Wisconsin, we're talking a Midwestern state, a state with interesting, like a purple state, a state with different political makeup and control over the governor's office and the chambers. What are states that are similar to Wisconsin doing when it comes to public health policy? Because that might be a way to learn from either very successful ones or unsuccessful ones. So that's a little bit of big P policy. Now let's talk a little bit about little p policy, or non-legislative policy. This is an area where I will say what we learn in our policy academy, for example, it tends to have a lot more accessible entry points for a lot of public health professionals who do want to take their expertise and turn it into some kind of policy change, just because the legislative process can be overwhelming or have particular barriers. We want you to be educated on both because both are an option and both come with several different strategies and tactics. But little p policy, because a lot of it can happen internally, for example, within the health department, within a county, within a hospital, can sometimes feel a little more accessible for folks. So what does little p or non-legislative policy include? Well, that can include things like you create guidelines, right? Maybe your jurisdiction wants to create their own DoxyPEP guidelines and mirror them off of the CDC's. Maybe you want to add some differences based on the populations you serve, right? So creating some kind of guidelines or updating existing guidelines that might not be adequate anymore is one of the ways that you can do that. Also, standard operating procedures and protocol development. This is another really key and sometimes accessible component of non-legislative policy, where you might say, I work with the DIS all the time, and we recognize that something is not happening around, this kind of conversation with folks. And so we want to go back and look at the DIS manual, or we want to go back and look at the DIS training curriculum, and we want to advocate to change for something, right? That's you enacting a policy change. That's you saying this manual, it's not up to date enough, or it's not adequate enough around, this particular component. So advocating for protocol and procedural changes, I know on paper that does not sound sexy. Like, people do not get excited necessarily when they see protocol development, but I'm telling you, especially in the public health world, we know this is such an important mechanism for change. I mentioned earlier that sometimes little p and big P policy is where the regulation process kind of does the electric slide. And that's because, legislatures can grant authority to, like, for example, health departments or other regulatory agencies to implement or enforce rules, which kind of lands it in your territory sometimes. And like I said, I keep teasing it, but we're going to do an example in a moment. So don't underestimate the power of implementing rules or regulations and what that process looks like. And then finally, something else we're going to go into in depth, well, as much as we can in a 60-minute webinar, is coalitions, campaigns, and capacity building. This is the area where you put your expertise into action, I would say by engaging with community and by making sure community outside of the public health realm understands what's going on. You get the community expertise in return. And again, it might not look like policy on paper to some folks, but at NCSD, and especially in our policy academy, we make the argument that doing that kind of work is creating policy change. So that's why we include it on here. Okay, I told you about this like mysterious example. So here she is. A little biased. I live in Denver and I'm born and raised Coloradan. So I picked a bill from Colorado. So sorry for my clear bias showing in this. But it was a good example. So this shows you a little bit about how big P and little p policy interact. So this is a bill, HB 1456, that was passed in Colorado's legislature last year. It is legislative policy in that the legislature approved it, right? The governor signed it. It includes requirements around HIV and prenatal syphilis screening. However, sorry, I have a brand new kitten and he just like slammed against the door trying to get into the office. He is not coming in right now, so apologies for that. Anyways, so they're establishing legislation, right? But the little p component of it, I'm going to read out loud to you because it's kind of small. But it says here, at least every 3 years, the Department of Public Health and Environment shall review the rules promulgated pursuant to this section and basically in alignment with national standards. It also says that same department shall make relevant stakeholders aware of the review. So that is granting the health department a little p policy opportunity, right? The government creates this rule around HIV and prenatal syphilis screening. And then it tells the health department, hey, you have the expertise to review these rules, and you need to make sure relevant stakeholders are involved in the process of reviewing those rules. Well, that goes back to that coalition campaign. That's an opportunity to engage community on the rules review process and for the health department to make some decisions around who some of those relevant stakeholders are. So just a good way to look at the way these two interact. Okay, we'll keep this part a little brief because I don't know how Civics 101 folks feel like getting. But it is always good to also review what the legislative process in and of itself looks like. So this is, of course, the unsinkable bill on Capitol Hill from Schoolhouse Rock. I mean, like how many years later, this is like our only reference I feel like we have in the world for the legislative process because it just makes the most sense. But just a quick refresher, and the reason we're doing this refresher is I want you to think of the areas where you might be able to engage with your public health expertise through the bill's life cycle. So a bill is introduced, right, by a member of the state chamber, unless you're in Nebraska, where you have just one nonpartisan unicameral chamber where they're all called senators. It's a fun fact about Nebraska, if you didn't know. The rest of the states have Senate and a House. They might call the House their General Assembly or something else like that. But nevertheless, somebody introduces the bill. It's introduced through a committee or a subcommittee. And I say here, look at my little virtual sticky note. Health committees are probably the most important ones to look at because the kinds of bills that we are interested in, we being the general like public health world, are probably coming through that committee or subcommittees, depending on how the state is structured. Keep in mind, though, these bills sometimes bounce around through committees before they actually get to a vote. Because if a bill has like a financial component attached to it, let's say, it might have to go through an appropriations committee or a joint budget committee or, you know, whatever the state decides to call it. But nevertheless, it goes through committees. It eventually makes it to the chamber for a vote, right? They vote on it. We know that it goes back and forth between the House and Senate, especially if amendments are made that may or may not have been in the news recently on the national level, in case we were not following the one big beautiful bill, though I think most people here probably were. And then, of course, if the bill becomes law, the governor then either signs it or vetoes it. I will say in some cases, the governor can just not do anything and then it automatically becomes law. Like if they don't veto it, they just kind of chill with it. A governor may do that for various reasons, maybe political reasons if they don't want to sign it into law, but they don't want to veto it either. But nevertheless, that's its little life cycle. Something you can do if you're trying to understand how this looks in your own state legislature is maybe find a bill that does relate to health or public health that you thought was important, especially one that became law. And then I would go back and look at what committees did it go through? Who introduced the bill? Who voted for or against it? Was it very bipartisan, just sailed right through? Some syphilis bills have been sailing right through with bipartisan support. Louisiana's this year passed unanimously through all support in the Senate and House. But anyways, look through that and it kind of gives you the ability to do some detective work if you're trying to understand like who cares about public health in my state legislature, who doesn't, who might, depending on the amendment. So it kind of gives you an opportunity to go back and look at the process. Um, and I know that Wisconsin being the focus of today makes this actually particularly interesting to me because Wisconsin is one of very few states, again, in the US, where there is not a trifecta of political party control. So trifecta meaning the governor, the House, and the Senate are all the same party, right? Wisconsin's one of those few states that, along with four others, that has a Democrat governor and a Republican-controlled House and Senate. And then there's a couple other states where it's switched. And then there's like Alaska, Pennsylvania, and Michigan, and those, and technically Minnesota. And those are the only states where the Senate and House are not technically in control by the same party. Alaska's is very interesting. It's like a bipartisan coalition. We're not going to go into details on that, but I'm just telling you, look up Alaska if you're curious, or look up Minnesota because their year has been wild, including having the House tied for the first time since the 70s. So those are my fun facts. I love to sprinkle those in. Okay. I'm going to let you all do some engagement now. So we've started talking about policy change. What do you think stops you from taking any kind of action, whether that's legislative or non-legislative? What feels like the biggest barrier to you right now? I would love for you to sound off in the chat when you're thinking about any of this stuff. Again, protocol development, coalitions, campaigns, legislation, whatever it is. What feels like it's stopping you from being able to move forward? Feel free to just put in a couple words, whole sentences. Okay, I see bandwidth, feeling ineffective. Yep. Great. I'll wait for a few other folks to have some time. I know this is one where folks might need to process a little bit, but feel free to, okay, money and funding. Yes, funding's a huge one. Can be really complicated, not knowing where to start, feeling uneducated, not enough time or resources, not knowing enough. Okay. These are some really great points. These are and the people, wait, sorry. As far as protocol development, the people over you don't want to listen. Ooh, that's a really good point. You know, we talk, we're not going to get as into much to detail with this, but we like to talk about that as gatekeepers, how to engage with gatekeepers who might, for various reasons, be stopping your idea from moving forward. But these are really, really great points. Public health funding is unsurprising to me, right? We all know in the public health world that funding is a huge barrier. Don't think that one's going away anytime soon, but there can be ways to think through policy change in a limited funding world. And then I'm hoping that what we're talking about today helps you all with some of these barriers and at least giving you some confidence and knowledge of maybe where to start, maybe how to develop a first couple of steps. So this is really helpful. Oh, and one other thing that someone just reminded me of, I'm gonna get this link ready for my next part here because I saw something about lobbying. So we're gonna get into that in just a moment. Okay. So speaking of, one of the things that can hold people back is not having a clear understanding of the difference between educating versus lobbying policymakers, because a lot of us are in roles where, especially on our public time, on our paid time, we are not allowed to lobby in any fashion. Fair enough. I'd love to explain briefly what lobbying is. Where I thought of the link is, while I'm going to explain it from a broad perspective, this is a nice little lobbying definition of every state. It's pretty similar across the states, but as we know, states like to act differently. And so just go ahead and check that out if you want to look at any state definitions specifically. But what is lobbying? In some ways, lobbying is actually pretty specific, you guys. Like it is going to a policymaker, going to being either in person, electronically, whatever it is, and saying, can you support, oppose, or amend this bill? right? A lobbying ask really looks like, can we count on you to vote no for SB blah blah blah? It's pretty specific, and it's either asking them to do that, or you're doing it on behalf of someone else, or you're asking someone to do it on behalf of yourself. So it really comes down to that core process of asking a policymaker to support or oppose a bill. Now, what does educating look like on the flip side? Well, one, it's not doing that. But two, it's really just stating factual information. And you can state factual information in many ways, right? So that's what some of our little do's here are. And again, this really applies in particular to folks who tend to work for government agencies like state and local health departments. Some of you may be working for CBOs or hospitals or other entities. And so I do always encourage that you consult the leadership just to see if there are any different regulations. Some community-based organizations do an advocacy day, for example. So depending on where you work, it could look different. I just want to be clear about that. So this is kind of the most conservative interpretation in some ways. But what does educating look like? It's explaining what your department does. Per my point earlier, your policymakers probably do not know what the STI prevention program does. I mean, probably not in general. I would quiz them on the difference between chlamydia and syphilis. Let's see what happens. And so just explaining to them, like, hey, this is what we do every day. Do you know this is what DIS do in the community? This is what public health nurses are doing for our community every day. They might not even know that. Just explaining it can sometimes be a very helpful way to educate a lawmaker. And you might be surprised, without any kind of bias around people's, politics or backgrounds or whatever, you'd be surprised what people think when they learn about what goes on in certain parts of public health. Sometimes people really change their mind. Per my point about some of these bills passing pretty unanimously in some states. Emphasizing STI rates. Do they even know that there's a syphilis crisis or epidemic in the United States? Again, chances are probably not. So emphasizing those rates in your particular jurisdiction. I'm going to combine this third one with the second to last. So cost savings and what funding can do. Again, it might be lobbying if you were saying, can we count on you to support this bill that adds $300 million, blah, 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 blah. But if you're just factually stating, like, this is how we spend money, yes, with this money, this is how many DIS could be hired, or these are the cost savings of HIV treatment when we have more folks taking prevention medications and being able to avoid acquisition, right? These are, again, factual information. Going back to that cheating off your neighbor's paper, right? You can provide examples of other jurisdictions. In Missouri, this bill passed. Here's what happened. It's important to note that this is the way this policy impacted this community, or whatever it is that you're referencing. And then, of course, whatever your departmental priorities are, that's something you can articulate. That is something that I think works particularly well for those legislative liaisons or those other folks who have different roles within the public health realm where they do regularly interact with the legislature. If you're building a relationship with that person, even just being able to say, like, our top priority this year is these three things. If those three things weren't on their radar, now they are. And if bills start coming up and they're like, ooh, this is going to impact this, they might know to reach out to you to ask for some data, to ask for some, information that they might share with policymakers. Okay, I have a love-hate relationship with this chart. I'm just going to call it out. I think it can be very beneficial, but I know it can be overwhelming. And here's the deal. This is our effort to talk about how you can start to engage with community in different ways to put your public health expertise into action. This is not an exact science. So what is an advisory committee, commission, alliance in one community might look a little different in your community. I just want to say that now. I don't want people walking away being like, it is always this, because that just might not be the case. But what you see on the top axis here are different entities that you can engage when it comes to community work and also getting technical support on policy change. And then on the left, it's kind of like the activities that you can do. So, I see a little comment in the chat. I'll just call out that we solicit our community for its input and share their responses with state level policymakers. Thank you, Marianne. That's a great example of something that you can do. It's community input, and you're sharing factual information with not just policymakers, with their constituents, by the way, their voting constituents on. So for example, like if you got that data and you're meeting with a policymaker from a specific district, if you had the ability to aggregate that data and say, people in District 18 said this, guess what? That policymaker going to listen because that's their district. So yeah. Okay, going back to this, I'm just going to go through this kind of briefly. I just want people to have an idea of what different options exist. There's advisory committees. These tend to be folks who provide really technical assistance. So like if you were looking at a policy that it impacted HIV drugs, maybe you'd go to the State Drug Assistance Advisory Committee, right? People who have technical knowledge on something. Commissions tend to be more civilians or like a sort of civic engagement structure where people are like appointed to a commission, usually for something maybe specific. Like I'll give a couple examples of my personal life outside NCSD because I think sometimes examples break it down. I'm on an advisory committee here in Colorado for our public health option plan on the marketplace. I'm on there as an individual, right? But there's people on there representing the insurance industry, representing hospitals. Advisory committees tend to have that kind of mix. Whereas I'm on an LGBTQ commission in Denver, that is LGBTQ citizens just engaging in commission work. So that's why advisory committees are really good for TA. Commissions might be really good for just engaging the community. Alliances tend to be the broadest of everything we're talking about. They might just, it might be an alliance of public health entities, and they are coming together under a broad umbrella for all things public health. And then a task force might be a group that's doing, again, a task. So they might be doing like a short-term, some kind of short-term strategy. And then coalitions, which we'll go to in a minute, kind of represent a little bit of everything. And coalitions are like alliances where they tend to be broad, but coalitions usually are a little more flexible. So like I said, this is something to check out. If you look at the things on the left and then you're comparing that to what you want, what kind of policy change you might want to see happen, or what kind of expertise you want to put into action, this might help you figure out like who exists out here. You can even look at these entities on the top and say, okay, who are the advisory committees in my jurisdiction? What commissions exist? Is there a commission on maternal health? Is there a maternal health alliance task force, right? What exists on maternal health? Maybe that's the group I want to engage. So that's why I kind of recommend just doing your own sort of analysis of where you live to see what's out there. And Chris, I'm glad you like the table. I do like it too. It just can be overwhelming. So that's why I say I have a love-hate relationship. So part of what you need to think about sometimes is, do I even need a coalition? Is this one way that we need to move forward with putting my expertise into action? These are just a couple questions. Again, I know it's surface level, but these are some questions you could put that you can use to kind of assess if you think a coalition is necessary for something. So is there a broader long-term mission, or is it something really specific where a task force might be more applicable? Do you need a diverse range of resources? Do you need groups and individuals who will advocate maybe more directly than you're able to, and you want them to be a part of the coalition? If there's no one working on the topic yet, that's a great indicator that a coalition might be needed. And then similar to what I just said about a task force, but if there's just no need, or if there's a need for action beyond feedback. If you're looking for just feedback, that's where that advisory committee and that commission might be more applicable, right? Like we've already created something, we're just trying to get some additional input versus like, no, we have a broad goal and we need to work towards it. And then what role can the public employee play in coalitions on public time? This is a helpful little reminder. If you are, again, especially if you're working for like a local or state health department and you want to be cautious about this, you can be involved in coalitions. I mean, I would still speak to your internal team to know what those parameters might be. But these are some general good rules for how you can show up in a coalition. So you can generally not lobby. That's kind of what we already covered. And that really includes all the things that come with lobbying, like asking other people to do it for you. And then, of course, working for a governmental entity, you don't want to share, of course, any confidential information. Not that anybody here would, but that's just something to keep in mind. And then what you can do is you can support policies through non-lobbying mechanisms. So instead of lobbying, you can, help people maybe do reviews of best practices, look at what other jurisdictions have done, help identify best policy options. What I think one of the most important things you can do is explain implementation processes. And what I mean by this is if you are in a coalition with a wide range of individuals, if you work in public health, you know how systems work, right? Because you have to deal with systems all the time. You have to deal with bureaucracies. You have to deal with health insurance systems. That's a huge one, or just healthcare systems, I should say, as a whole. And so when folks are developing in coalitions their strategies, you can be that person to be like, ding, 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 here's how this works, y'all. Like, just FYI, this is how this process works. This is how the government implements XYZ. This is the thing that it doesn't implement. You can help really educate folks on these processes. And then, of course, share the things that you can share, your expertise, the data you have access to, the contacts you might have, any information that is okay to be public. Please feel free to share that, because there's a lot of folks out there who are not regularly combing through public health data, but the data is so important, and that's one of the ways that we can share it with folks. Okay, this is my last section before we go into some Q&A. So lastly, I just kind of want to talk a little bit about messaging. Whether you're in a coalition, whether you're having that one-on-one with people above you in the health department and you're trying to be like, okay, I'm going to get you excited about this. You're going to want to move forward with me on this idea, or whomever your audience is. Effective messaging is a way. I saw a lot of people in the chat say, well, I don't know if I'm being effective or not. Developing and refining effective messaging will help you feel more effective, because you'll see that it starts to get people to notice or care about what you're talking about. And so these are just some quick facts about some effective messaging. Being concise and clear and avoiding jargon. You almost have to do like 3 jargon reviews. And I say this with love because I also work in public health and I throw out jargon all the time. I mean, even my friends, I'll be at a bar and be like, well, USPSTF and blah, 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 blah. People are like, what? What's USPSTF? I'm like, oh yeah. I'm like talking to all these people on prep, but they're like not thinking about what that is. And I don't mean that in a bad way. I just mean like we just don't always know what people know. Congenital syphilis. Again, that's kind of jargony to some people. So just go through and really think through, how can I talk about this as clearly and concisely as possible and not use all the jargon? And kind of tell a little bit of a story. What's the problem? What's the solution? What do I need you to do? That's a great way to talk to people above you. If you're trying to say like, this is the problem we've noticed. We have a solution to modify the DIS manual. We kind of need you to authorize this part for us to move forward with it. Or we need the chief medical officer to approve or be involved in these doxypep guidelines, or whatever it is. Make it very clear what needs to happen. And again, fixate on some of the compelling components. Storytelling can be very important. And also just the practical components. Why is this going to save money? Why is this effective? Etc. So my last little part here, I have a couple slides left. And I think we should be good on Q&A time. So I just want to provide you some examples of what I thought was some pretty effective messaging from 2025 state legislative activity, all related to STIs. So I'm going to show you a bill. All of these bills became state law. And I'm going to show you a quote, either from a policymaker or a public health professional around the bill. That may have taken place that did take place at some point during the development of the bill's life cycle. And I just think these are all really interesting and effective messaging. And again, all 3 of these bills became law, so we could argue that in some ways this messaging contributed to that. In Nebraska, LB 41 became state law this year. It unanimously passed the one chamber in Nebraska. LB 41 expands prenatal syphilis screening requirements in the state of Nebraska to include the 3rd trimester and at delivery. And it explicitly includes an ability for the person to opt out of that testing. Okay, so here's a quote that I think captures all that messaging that convinced those Nebraska legislators from the person who introduced it. He said, these numbers represent real families impacted by their very first preventable disease, but also ensures that while we strengthen public health protections, we also respect personal autonomy in medical decision-making. So I just want you to think about that messaging and why that the combination of those two things probably were very successful in Nebraska's legislature. In Nevada, AB 360 became state law. This is a bill that enables emergency room personnel more explicitly than the law previously did to use rapid syphilis tests instead of relying exclusively on laboratory-based serological tests for prenatal syphilis screening. This is the fabulous Jen Howell of Northern Nevada Public Health, who I've had the absolute privilege of interviewing before. She is amazing, so I just have to give Jen a shout out. And her the Northern Nevada Public Health created a fact sheet, by the way, about congenital syphilis when this bill was up and running. So again, they were what? Educating lawmakers. They didn't, that's not lobbying them, but they educated them on congenital syphilis. And then this is a great quote from her. This bill ensures rapid syphilis testing in emergency departments. Strengthening early detection at every point of contact in the healthcare system is essential to protecting maternal and infant health and ending congenital syphilis in Nevada. And then the very last one, SB 79 in Missouri. Another bill that, well, this bill did a lot of things, but one of the things it did was expand prenatal syphilis screening in Missouri. I have two quotes from two Republican state legislatures in that state at the top. This bill is really about maternal and infant health, making sure these mothers have the care they need so their babies can have the care they need. Healthy moms equals healthy babies. By the way, healthy moms, healthy babies, the name of Arkansas's act this year, not just signed into law by Sarah Huckabee Sanders, but championed by her to do presumptive Medicaid eligibility for pregnant individuals in Arkansas. So that healthy moms, healthy babies thing, that is working in some states. And then I have a great quote from our fantastic NCSD Missouri member, Dustin Hampton, that says the populations that are experiencing syphilis increases now may not even be aware that they're at risk for syphilis. So we see kind of a nice public health professional take on messaging with this quote. Okay, I think I did well on time. We are at the Q&A section. I don't know if we have Q&As in the chat, and if not, it looks like we don't have any open ones. So I would love to, oh, thanks, Adele, for doing that, for pasting the info sheet. That's great. Yeah, I know that was a lot of information, and sometimes people are also processing, but would love to see if we do have any questions or comments from folks. Even if it's not a question, maybe there's just something you want to share. I think folks can either do it in the Q&A box or the chat, right? They can't come off mute. No. Okay. Yeah, so those
Yeah.
are the two ways you can do it.
I'll watch both. I'll watch the Q&A and the chat. Yeah, we can just take a couple minutes to see if some questions come in. I suppose while we're waiting for people to formulate any questions, I can just explain. Actually, Chris, would you mind sharing the slides one more time?
Sorry.
No, you're
Right,
okay.
there's another slide, isn't there?
Yeah, no, that's okay. I'll just go over that real quick while folks are thinking of questions.
I forgot. Thank you.
Yeah, no worries. So this QR code that you see is a link to our post webinar eval. We really appreciate you filling that out. That is also going to be this post eval is going to be in the thank you email that you'll receive following this webinar. I will also put in this link from the Interesting Nevada info sheet just because it's cool. And then that post email will also have these slides linked in it. Some people were wondering if the slides will be included. Yes, they will be. If you're on this webinar, but you did not register, that means I do not have your email so that you will not receive anything. So what I'm going to do is for folks that maybe are on here because someone passed you the link, I'm going to put my email in the chat. Please email me if you want to make sure that you get the follow-up email with the slides, because if you didn't register, I don't have your email. So I'm just going to drop my email in the chat for any folks who need it if you did not register ahead of time. Let's see if any questions have come in.
Well, while you're doing that, I will also put my email in the chat as well, just in case folks are like, yeah, I maybe have a question, but I don't feel like asking it right now, or I want to do a follow-up. So please feel free to send an email. And I'm going to plug the evaluation too, because, Diane and I are always, whenever we do our webinars, I know this HCET, Diane and I are always like, don't forget to take our eval, everybody, because it's very important for quality review and improvement.
I was just thinking the same thing.
Yeah, thank you in advance. Yeah, does anyone have any thoughts? Even if you don't have questions, feel free to drop them in the chat or put them in Q&A. We'd love to hear from you. I know there's a lot of people on today. Thank you so much for joining
Yeah.
us.
And I'll say, while people are formulating, feel free to check out our website. Diana mentioned a bunch of state policy efforts at the very beginning, and I'm just replugging them because they might be helpful for some folks. If like this month in state policy is not as active right now because we primarily do it January through June when most state legislatures are meeting. But you can go back and read our analysis of the policies that we were following during the height of state legislative activity on our website. Diana mentioned the success stories. It's kind of a nice way to be inspired by what's happened in other jurisdictions. And with that, I will also say Diana and I are always looking for other success stories. And so if there's something happening that you're like, hey, how come this hasn't been featured? Maybe we don't know about it. So let us know, because maybe we can feature it. Even if it's not this year, we might be able to do it in future years. So yeah. Elena says, not a question, but this is super helpful. And I appreciate the section on educating versus lobbying. Okay, great. Thanks, Elena.
Yeah, thank you, Elena. Oh, I have a question.
Oh,
So
okay.
one of the final things you talked about was, getting the effective messaging. If
Mm.
I feel like I'm a person who cannot be very concise, which is true, is there a place I can look for messaging that's already been proven
Ooh.
somewhat effective in my field? Like, where would I kind of look for that messaging if I'm not good at crafting it myself?
Yes, yes, yes. Great question. I will say there's no shame in that because in the public health realm, we tend to it is hard to be concise because if you work in public health, you tend to love information. Okay. And so it's very easy to want to be like, and blah, 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 so there's no shame in that because like I said, I'm talking to people about USPSTF at the bar. So clearly I also know how to not stop talking. But I would look at a couple different things. Going back to the investigative process when you saw bills that became state law, that whether it's your own state or not, if you saw a bill become state law that you thought is a really good bill for public health, I would go back and look at any testimony for that bill. I would look at any articles about it, any quotes from it. I would look at anything to see like what were people saying around this bill because clearly it got a lot of support. So that is one way to look at some effective messaging. I would also look at policy briefs on topics that you like. Policy briefs, by definition, are supposed to be fairly brief, although some people take them in all kinds of directions. But I would do some research on policy briefs around certain topics because then you can look at how people have condensed that information. We could provide a few examples ourselves if you wanted that. And then even just I mean, I know this is kind of simple in some ways, but even just Googling some of the public health messaging tools that exist out there, there's a lot of good ones. I don't have the links for them. I have them in our resource library, but I don't have it off the top of my head. But sometimes just going through and reading some of those best practices for how to be concise. You know, the way I said it earlier is like there's problem, solution, and action. Sometimes using that framework can really help you narrow it down. So like a policy brief has an executive statement, right? And so it's kind of like a thesis. Sometimes I recommend trying to write the thesis itself and give yourself like 3 to 5 sentences, period. I'm going to say a problem, a solution, and an action and kind of massage it a little bit. And it just kind of helps you be like, okay, if this is the only space I have, what am I cutting out? And then it looks like Diana might have put another good, oh, thanks, Diana. Yeah, another great tool in the chat too. So I don't know, Adele, does that kind of capture some of that, or what do you think?
Yeah, that's super helpful. Yeah, I just really would not try to come up with it myself. Oh, it looks like we have a question come up too. Um,
Oh,
this
sure.
one says, how do I talk about policy with my higher
Mm.
ups when funding cuts are happening? For
Ooh.
example, I think DIS should be trained on being a medical assistant so that when they're out in the field, they can do rapid syphilis testing. And when they have a positive, they can administer penicillin. It's a really good question.
It is a really good question. So okay, I'm gonna try to give a brief version to it, and then Diana, I'll feel free to jump into if you want. You know, when we talk about navigating a gatekeeper, again, it's not a bad thing to be a gatekeeper necessarily. Gatekeepers are doing their job. And if their job is, we have a limited budget and we can only do so many things or X, Y, right? That's going to be the perspective that they're going into it with. So sometimes what we say is almost kind of create like a Venn diagram where you could be like, here's my needs around this policy and here's their needs. And do we line up on anything? And if we don't line up on money, then we kind of need to know about that when we're going into the conversation. And so part of what that could look like is coming up with alternative policy options where you might say, this is the ideal. And because we do not have funding for the ideal, I am proposing this. Because it kind of shows that you've thought through the limitations already. And it kind of shows that you're saying like, yeah, because you were talking about medical assistance in the field. So yeah, so for example, like what are some other ways to ensure rapid syphilis testing? So maybe if it's something DIS can't do, are there other medical professions? Washington passed a bill last year that allows medical assistants to do injectable treatment in the field just under telehealth supervision instead of it needing to be through physicians. So like even just researching, like, are there some other folks that have circumnavigated this a little bit, and can I propose that? While I think still saying like this is the ideal way I think we should do this, I just recognize that we have financial limitations and I'm proposing this instead. So that's one strategy. I saw Diana came off mute, so I'd like to kick it over to you.
Yeah, great. Thank you. What also comes to mind is data, using your data. So if you can demonstrate that, having a DIS become a medical assistant and going through the cost of that, but that will in turn maybe prevent X number of infections or catch, X number of infections, you can see that there's a cost benefit there to that cost analysis. And so that might have some weight. And then, for rapid syphilis tests, I don't, there are some ways to purchase those that can be, maybe you can use different funding streams potentially. If it's tied with HIV prevention, you might be able to leverage Ryan White rebate money or something like that. So, but yeah, I just wanted to throw those two ideas out.
You know what I'll add to that you just made me think of, Diana, is the timing of this can also play a key role because Diana brought up a really good point that there could be other funding streams that you can use. Or ones that seem like they're at risk, but maybe you don't have that confirmed yet. And so sometimes having a grasp on the timelines can help you figure out a way to when is the most strategic time to meet with them. So let's say you think a funding stream is going to go away, but you don't know that for sure. And if it doesn't go away, you think it might be able to be leveraged, through, for example, through the data that Diana just mentioned. Maybe you plant the seeds with them, but wait for a certain time to have the meeting. So sometimes scheduling the meeting that you have with the person, being really strategic with the timing can help you also with that question. But I will say that's a tough one considering again where we are at right now with public health funding. I think that this landscape is not favorable to public health money. And so I think that is going to be one that's a continued strategy to think through. So I do appreciate someone bringing that up because I think that's tough. But there's creative ways to do it, whether that's someone else's providing that same testing and treatment. We're looking at different funding streams or waiting for the right time to bring it up, etc. So, yeah.
Yeah, thank you for that question. And thanks y'all for thinking through that. We will give it another 60 seconds to see if any other questions come through.
Oh, I think we have one more, don't we? Oh, thanks. Yeah.
Yeah, this is really interesting. I have to say, like, I'm on a board of directors for a coalition, and honestly, until seeing your table, I was not sure what the difference was between a coalition and a committee and all of that. So I feel like I deserve my spot a little bit more now that I know the difference.
Well, that's good.
I see. Okay, good. I see some thank yous. Yeah, thank you all for attending. Oh, I see another question popping in. Oh, just says thanks. Thank you. Thank you for
Yeah.
attending. Thank you to Diana and Chris for joining us today and, letting us discuss a little bit more about this because you're right that this timing is is difficult. And so I know we all want to do what we can, and the work that you all do is so important. So thank all of you for joining us. Thank you, Jen, for tech support. Thank you, Chris and Diana. We can let y'all go.
Awesome.
Thank you,
Thank you all so
everyone.
much.
Thanks.
Oh, thanks, Monty.
Bye.
Bye, everybody.